these patients would like or would benefit from a multidisciplinary outpatient follow-up, particularly a low vision clinic, I would say. We have at Duke the low vision clinic, which comprise of the occupational therapists who are trained to diagnose as well as provide compensatory training, as well as they have ophthalmologists. And we as a neurologist are involved as well in terms of progression of those patients from the stroke standpoint. So there is a big role, and I think the more we start looking into this, I'm sure there will be more utility of this kind of clinic setup or multidisciplinary setup, because once you lose vision, even though there is some improvement, they may not be safe to drive unless you actually get a confirmed diagnostic testing. And I can tell you from my experience, we had a patient who came with visual field deficit. He was clinically cleared, really objectively no clinical impairment by the time he was discharging. I happen to have automated perimetry, which is a VR-based system, which I'm using for my own research. I just did that on him, and I found a clear hemifield deficit on that patient, which was not picked by clinical exam. And I had few of those patients with the same issue. I think so. We don't do a good job in objectively screening those patients when we discharge them. And I think these patients need to be followed up, even though they're clinically fine, because if they start driving and in the low light area, like at night, that's where actually they will have more impairment, and we may not pick it up just based on a clinical exam. I would just like to tell all the viewers that visual impairment, again, is a very critical part of how we live. We cannot live without seeing anything. We need to read, we need to use the vision for communication and everything. So I think it's a critical piece. We need to spend more money for the vision related research, and I think more people should come and help come up with a treatment plan for post-stroke vision impairment.